So eczema and dermatitis are the same, but there are different subtypes of these conditions. One of the more common presenting types of eczema or dermatitis is atopic eczema, which is usually prevalent from a young age or infancy, and it's linked with the atopic triad, which is eczema, allergic rhinitis, and asthma. In this condition, it's often very difficult for parents because the young infant or child has quite severe eczema, and we need to manage that reasonably well to make sure that they're not missing any childcare, school, or sleeping properly, as well as eating well as well. So that's a very common form of eczema. However, there's multiple other subtypes of eczema. We can get things like discoid or annular eczema, which often gets misdiagnosed as tinea corporis because it looks annular on the skin. There's also venous eczema, which is common for elderly patients because they suffer from venous insufficiency, and that problem in turn makes the skin very dry and xerotic, and then they can develop an eczema of the lower legs. There's also asteatotic eczema, which is an eczema pattern we can see over the lower legs and lower abdomen. And one of the more common things we deal with is either irritant or allergic contact dermatitis as well. So irritant contact dermatitis is where there's gradual chemical breakdown of the skin, and that can create irritancy over time. And allergic contact dermatitis means any time that chemical touches the skin, they get a severe, almost blistering sunburn-like reaction. So to tell which dermatitis is which, often again history is key. So as I said, atopic dermatitis usually presents at a younger age. However, also the distribution and morphology of the eczema is important. So for example, typically atopic eczema presents in childhood in the flexural areas, potentially also on the face. So the history is important, also family history. So there's often a family history of atopic conditions. The morphology of lesions is important. So the way we describe or see different types of eczema is important. So for example, if it presents primarily on the lower legs, we know it's either going to be a venous eczema or an asteatotic eczema. Asteatotic eczema often has a what we call eczema craquelé, or sort of dilapidated brick sort of look to it. So we can usually determine that clinically by the look. Discoid or annular eczema is usually annular or semi-annular in nature. As I said, a lot of patients come in thinking they've got what they call ringworm, which is a misnomer for tinea, but the pattern is quite different because discoid eczema has inflammation and scales throughout the entire patch or plaque of skin, whereas tinea has more of an advancing inflammatory scaly edge. When we look at contact dermatitis, we've got to take a good history about the person's occupation and their hobbies and look at where it's distributed. So if it's primarily all over their face, then it's probably something they're putting on their face. If it's hairline and scalp, it'll be something they're using on their hair. But very commonly we'll see things for hand dermatitis in patients that do certain professions such as hairdressing, for instance. With eczema management in general, so we want to avoid any irritants on the skin. So we avoid things that are too drying. So things like soaps are not good. We also avoid irritant clothing materials. So we avoid things like wool and polyester. So cotton clothes are often the best. But in terms of skin routine, we want to use a really good soap-free wash, of which there's many out there. There's also some slightly fancier products out there now, which are like cleansing body oils, which almost add moisture to the skin. So if we can retain the moisture in the skin better and create a barrier function, that's always going to work well. So number one, we want to use that in the shower or bath, and we also don't want to have too long or too many showers or baths. So in winter, the skin tends to dry out more frequently because we have longer showers, longer baths, heating is on, the air is less humid, so we dry out our skin, which can worsen eczema. So we need to use the right products while showering, and then after showering, we want it to put on a really good moisturizer or emollient, and that can range from being very light as a lotion, medium sort of is a cream, which has a mixture of oil and water, and then we can go to thick barrier ointments, which don't have any water component. These are actually the best for eczema protection in terms of barrier function because they last longer on the skin and create a good barrier function, but some people don't like to use these all day because they're a little bit greasy. So we tend to stick with the creams or lotions during the day and put ointments on at night as a general routine. If eczema is flaring, however, and it's red and itchy, we definitely want to calm that down as quickly as possible, and the first line therapy for that would be a potent or moderate potent topical steroid, depending on what area of the body we're in. If we have eczema that's either not responding well to topical corticosteroids, or we need to treat because as soon as we stop the topical steroids, they rebound or flare quickly, which can happen in eczema. So we need to make sure there's nothing driving the eczema, and that's where we can do some blood tests to look for environmental allergens. We can look patch testing to see if there's anything physically going on the skin from products that's flaring up. But if that's not working, we've got several adjunctive therapies we can use. So there are topical immunomodulators such as pimecrolimus or topical tacrolimus. We also use narrowband UVB phototherapy, which we can use for full body treatment of eczema, as well as hand-feet eczema as well. If that fails, we can use different systemic treatments. So short-term acute use of oral prednisolone or an oral systemic steroid is useful for acute eczema, but not a good long-term option. And in the long-term options of severe eczema, we'll use medications such as azathioprine, methotrexate, mycophenolate, cyclosporin. And there's a couple of new medications out which are recently become available on the PBS in Australia. One of them is dupilumab, which is an injectable medication which works quite well, and the other one is upadacitinib, which also is an oral medication and has recently been put on the PBS as more advanced therapies for, particularly for atopic dermatitis.